I'll be talking about FFR-CT today. No disclosures for this talk. As you know that the cascade of ischemia starts with perfusion and then goes to metabolism and diastolic function and contraction. And therefore CT, and especially CT perfusion, is really on top over there. And this is very pertinent for diabetics, as our speakers had previously said that asymptomatics are the people whom we need to really look at, because they are the ones at high risk and we need to prevent ischemic episodes. So while we do that, we understand that the angiogram is the gold standard, or has been the gold standard, but it has a lot of limitations in that it's invasive, it is a luminogram, and we don't have a plaque character. So CT has come in as a very good non-invasive tool. And what it does is that it has a 3D volume which can be infinitely manipulated, and it has got plaque characterization, which is very, very important. And this is a 45-year-old female, has exertional shortness of breath, wanted a non-invasive study, and you can clearly see with the arrows a borderline lesion in the LAD. And of course, as is normal, patient underwent an angiogram, and the angiogram again shows a borderline mid-LAD lesion. And what do? The conventional wisdom is to do an IFR, and you got a number of 0.70, which is hemodynamically significant, and patient underwent PCI to the LAD. The second patient is a 54-year-old male with atypical chest pain, come for a health checkup, borderline lesion in the RCA. There is a mixed plaque, some lipid region is there, suggestive of a vulnerable plaque, angiogram done, borderline lesion, 50, 60, somebody said 70, IFR done, and then you get this 0.78 number, which is again hemodynamically significant and needs intervention. So with the prior two cases, we've seen that anatomy is a little deceptive. And while the CT is excellent in the two extremes, that is a normal and mild lesion, and of course in the significant lesions, it just does not cut it when it comes to the borderline lesion, which incidentally is almost 1/3 of all our work. And what happens here is that the positive predictive value really falls to less than 70% here, with a high 90s in the sensitivity. Now, how are we going to overcome this? This is where a real historical truth has entered the clinical scene. And this is contribution from Sir Isaac Newton, 1642 to 1727, who actually said that if I have seen further, it is by standing on the shoulder of giants. And this is the true principle of what FRCT has done by investing in the fields of fluid dynamics and coronary physiology and leveraging these technologies with modern equipment. And this is the state-of-the-art paper which came up in 2013 by the Redwood group, the HeartFlow group, which is the only commercial group at this point of time who is doing the CT-FFR. And what they do is they take the CT that we do, it is uploaded onto their web, they create an anatomic model, they look at the coronary flow, they make a physiological model out of that based on the myocardial volume, and harnessing the power of supercomputers, they create a simulated CFR. And this is just the technique that they use without going to details, the baseline technique, the no pressure drop. And here with the significant stenosis and hyperemic, you can see there's a drastic pressure drop. And with the myocardial volume, they create what is called the lump parametric heart model or the Wind-Kessel model. And this is where the CT-FFR is truly born. It was not until 2008 that Weboom, who's a Dutch cardiologist, really looked at CT and angiograms and invasive FFR and clearly showed that there's a huge amount of false positivity in the CT and the angiographic, despite using quantitative techniques. So this false positive, we understand that cannot be taken further for intervention unless we look at the physiology. And it was at this point of time that I must tell you that this is 2017 data, that when they looked at hypertensives and diabetics with FFR-CT, which is the topic for today, they found that the area of the curve doesn't differ whether you're hypertensive or diabetic, it is the same. And therefore, the relevance of FFR-CT in diabetics is very, very important. The first group of studies that came out was a Discover Flow study, multinational study, and they clearly showed that whether you use FFR-CT or invasive FFR, that the numbers are going to be same. There were a few outliers, as you see in red, false negatives and false positives, but most of the numbers were fairly correlative for both invasive and FFR CT. What is also important is they showed a huge increase in the PPF for FFR CT 74 compared to the positive predictive value of only 46 for anatomical CT. This was followed shortly by the de facto trial, and some good friends of ours like James Min was the author of this study. And here they looked at both CT and invasive FFR, and they realized that 10% of the scans were not available. I will just come to this a little later. And again, here they found in the FFR CT group compared to the conventional CT that what is really important is that the positive predictive value comes up quite a bit compared to the CT, while the negative predictive value is similar to both. And if you look at the numbers under the curve, you can clearly see that FFR CT really has an edge over anatomical CT. The NXT trial again was a large trial, international trial, and here also you could clearly see that the per vessel positive predictive value was almost twice that of the anatomical CT stenosis. And these are people who read CTs on a daily basis. What is important more than numbers is what is happening to the clinical outcomes. And this platform study headed by Dr. Pamela Douglas looked at two groups, the non-invasive group of investigation and the invasive group in patients who had coronary artery disease. And the non-invasive group had two arms, the usual care and the FFR CT, and the invasive group had the usual care and FFR CT, and see the number of unnecessary tests that have been done in the usual care strategy compared to FFR CT, and see the number of negative diagnostic invasive angiograms done in the invasive group compared to the FFR CT. What is more important for those of you who are interventionists is that the PCI and bypass numbers are extremely healthy, even in the FFR CT. So don't worry about using FFR CT. It's not going to decrease your income. What is very important is that when you use FFR CT as a strategy, the cost is almost equal to that of usual care in the non-invasive group, but there's a substantial decrease in cost when you look at it in the invasive group. Does this pan out in real world data? And this is Danish experience. And clearly they showed that when you have an FFR CT of less than 0.8, the stenosis in your vessels increase, the calcium score obviously are higher, and you have a very high MACE if you have an FFR CT of less than 0.7. And also if you have an FFR CT of more than 0.8, these patients are very safe over a 3-year period. And also what is important is that if you have an FFR CT of less than 0.8 and you do not revascularize your patients and keep them on medical management, they have a very high MACE compared to those you suspect to revascularization. So very good revasc data. Now, when you look at CT versus all the other imaging modalities like SPECT, CT, and PET, you can clearly see here that FFR CT is heads above shoulders of all the other investigations and is almost equal to what CFR can do in the PET. The real FFR CT study again showed some very good numbers of accuracy, but there is an alarming problem of a low accuracy, especially when it mattered in the 0.7 to 0.8, and that is one of the limitations of CT. CT has been also used in the emergency department. This is Dr. Kavita Chenian, close friend of ours, and this was shown that if you use FFR CT as a strategy, your clinical outcomes and MACE are lower than conventional CT. The costs are equal, the diagnostic failures are less, and the chance of you having non-obstructive disease in the angiograms is much less. So CT FFR as a strategy in the ER is also important. Moreover, they used vulnerable plaques in this pathway, and these are possible to be used, especially when the CFR is in the gray zone of 0.7 to 0.8. Recently, a Chinese multi-center study used a different strategy called the mask line, centerline definition, and mesh boundary, and found some very, very good numbers for FFR CT with the area under the curve of 0.9, amongst the best. And this is a classical example of a patient with an LAD lesion, and this is the same lesion on the angiogram, and you can see serial FFR CTs available, and the final FFR CT is 0.6, which measured that of the invasive FFR, and the patient underwent angiogram. What is more important is in the vulnerable region of 0.75 to 0.8, which I talked to you about. This Chinese study showed some very, very healthy numbers, and that FFR CT can be used despite the old FFR CT study showing that the accuracy was limited. What is also important is TAT, and most of you who work in big hospitals like me know that TAT is nothing but turnaround time. And from a 12 to 14-hour turnaround time, we have a turnaround time of almost less than 2 hours in mainland US. And now we have a system even on the laptops at this point of time. This is, of course, just early days in India, and so we'll possibly have more data. Now, this is a patient with a OM lesion. It's borderline, and you can clearly see that the FFR CT is not significant here, 0.85. Is it true? You need to look at the angiogram, same lesion, and you get an FFR of 0.84, which means the patient can be managed on medical management. This is an LAD lesion, looks important to me. And yes, the FFR CT also calls it important. And the invasive angiogram again shows it's important with the important FFR value. This is another patient with an RCA lesion. Looks important here, but the FFR CT is not important. The angiogram again looks important, but the FFR is only 0.88. And another patient with an LAD lesion, and this is the red color, this is the CT-FFR, which really matches with invasive FFR. Now, to the last part, the limitations include artifacts. And as you've seen in most of the multinational large studies, 10 to 15% of cases, you cannot do FFR CT because of artifacts. And this is very important to have a very good CT data. Calcium is a big killer for CT, but unfortunately, it is also a problem in FFR CT. And the red color is the patients with a calcium of more than 400. You can see the area under the curve is much less than if you have a CT FFR with a calcium score of less than 400. What about myocardium, which is dysfunctional, which already has an infarct? And again, CT FFR cannot really do a good job if the distant myocardium is non-viable. And this is the biggest problem of CT FFR. Between 0.7 and 0.8, the accuracy really comes down, and that makes it a little difficult. Coming to visual thinking, and we are in the festival season, these are images, beautiful images for patients post-bypass looking at CT FFR. But here, you can clearly see that this is not possible with the technique today. And we would like to see these images of a patient before stent and after stent. But again, CT FFR is not indicated in stents as of today. Thank you very much for your patient listening. Just going to look at the guidelines once. The US guidelines haven't recommended at this point, but the British NICE guidelines, after an independent appraisal, recommends FFR CT as an accurate, cost-effective option for evaluation of patients with recent onset stable chest pain who are referred for CCTA for workup. Thank you very much for your patient listening.